Thank you very much, madam. Vitreomacular traction syndromes, by definition, would mean there is an incomplete posterior vitreous separation, and associated with it, there is a pre-retinal tissue proliferation and traction. So, it is distributed in the zone of persistent vitreous attachment. So here, as you can see, is there a pointer? Yeah. As you can see, the vitreous is separated on both the sides, and only in this particular area there is a vitreous attachment. And that prominent attachment is also associated with a significant area of proliferation and epiretinal membrane formation there. So the distortion of the internal limiting membrane will cause retinal striae. You can see folding retinal striae and sometimes vascular tortuosity. Sometimes we can actually make out as a macular edema. So the localized traction related macular retinal detachment and retinal vascular and optic nerve staining will be seen on fluorescein angiography. Described first by Rees et al., both clinically and histopathologically. Okay, it causes a cystoid configuration of the edema and decreased vision. Most of the cases resolve spontaneously with completion of a posterior vitreous detachment, PVD. Now, how does it occur? So, delayed the reason why some cases proceed into complete PVD and some cases do not proceed into complete PVD and occur like a vitreomacular traction is not known. But these are the delayed posterior separation of an unusually prominent posterior vitreous surface or firm posterior hyaloid attachment, and that stimulates cell proliferation. And sometimes, primary pre-retinal tissue proliferation may limit the normal process of PVD. These are the different theories. There is no non-racial predilection. Most of the studies include 65% of women. Reported age range is 26 to 85 years. Ocular examination, there will be decreased central visual acuity, and some degree of metamorphopsia is what is most commonly experienced by patients. Even if patients have 6/6 vision, they may have significant metamorphopsia. Watzke-Allen testing, when you put in a very narrow beam of light on through the macula and then swipe it, then patients may report thinning of the beam, unlike in a macular hole where there is a loss of that central area. In many patients, the disease does not progress and the symptoms may remain at that static point of time for a long period of time. But a subset of patients progress from minimal to severe symptoms and reduce in visual acuity. The natural history of such patients is usually continued slow progression with stabilization of vision at about 6/60. So here, unlike in a macular hole or other pathologies, here we have an anteroposterior abstraction, which can cause more macular edema. Often a segment of attachment is visible as a curvilinear attachment when you are doing a stereoscopic biomicroscopic examination. The zone of vitreoretinal attachment typically involves a region of several disc areas central to the fovea. Okay. So that is a clinical picture of a vitreomacular traction. You can see the central cystoid pattern slightly, and you can see area of hyaloid, glistening hyaloid all around this particular place. So when you are doing a stereoscopic biomicroscopic examination, around this area probably the hyaloid is more separated, whereas when it reaches this particular area, it will become thicker and then it is attached. So that is something that we have to find through a slit lamp biomicroscopy. Okay, on a fluorescein angiography, here you can see a disc leakage as well as macular leakage. So the optical coherence tomography is the giveaway. Before the optical coherence tomography came in, stereo biomicroscopy and fluorescein angiography were the only methods. But with OCT now, you can pick up this hyaloid traction or the vitreomacular traction very clearly, and these are two cystoid spaces within it. What are the differential diagnoses? One is idiopathic macular pucker, but in an idiopathic macular pucker, Weiss ring is usually present, which means that there is already a total vitreous detachment, whereas here there is no total detachment. Stage 1 macular hole and lamellar macular holes, you cannot see the vertical anteroposterior abstraction is seldom seen. Prominent ILM stripling is due to pseudophakic macular edema. Vitreous attachment at the fovea and cystoid macular changes are found on the pathology. The pathology was done by Rees et al. In his described cases. He did a postmortem eye examination and found that there was cystoid macular edema and vitreous attachment, etc. Okay, retinal pigment epithelial cells were notably absent. Okay, this contrasts sharply to abnormally highly proliferative retinal pigment epithelial cells in a macular pucker. There is a difference between this and pucker. What is the treatment? If there is good vision, you will only observe. If the symptoms progress, then you may consider vitrectomy. So once the visual acuity drop, then only basically treat with vitrectomy. The surgical treatment is as in any other vitreous, any other macular pathology, 3-port vitrectomy. Generally now we use the MIVS techniques. Removal of anterior to posterior traction has been advocated. So here what happens is that you should not pull on the traction, because if you pull on the macular traction, you will engage you will cause a break in the macula. You will cause a macular hole. So it's better to trim around and slowly try to peel off that. That is the technique. Now there will be usually a double layer. Unique finding in the surgical anatomy, double layer. One is the pre-retinal proliferation, then is the ILM. The postoperative visual acuity was less than 20/100 in 70% of cases, increased by up till 2 lines. But the thing is, you have to wait till the vision drops down at least to 6/18 to do it. Thank you very much.